I'm trying to hide my excitement, but I
Oh,
am
thank you.
pretty freaking stoked to be talking to you right now.
Thanks.
Um, I'd like to try to get through as many questions as I can, but as long as you're willing, and if something doesn't, if we don't get to anything, and you have time at any point in the future, I literally wrote down about 100 different questions. Obviously,
Oh,
we won't go through all of
okay.
those, but
Somebody get this guy some help!
Disclaimer. This podcast is for informational purposes only. The information provided in this podcast and related materials are meant only to educate. This information is not intended as a substitute for professional medical advice. While I am a medical doctor and many of my guests have extensive medical training and experience, nothing stated in this podcast nor materials related to this podcast, including recommended websites, texts, graphics, images, or any other materials, should be treated as a substitute for professional, medical, or psychological advice, diagnosis, or treatment. All listeners should consult with a medical professional, licensed mental health provider, or other healthcare provider if seeking medical advice, diagnosis, or treatment.
I have some well-developed question stems that try to kind of get past the basics of what I think your response will be, and if I'm off in any way, then let me know. But that way, we can kind of move straight to some more pressing or more kind of modern takes on things. But I'll go ahead and get started if you're good.
Sure.
All right, so today I have on the podcast an absolute pillar of academic psychiatry, a psychiatrist who is in the running, in my opinion, as the GOAT of modern psychiatry, Dr. Nassir Ghaemi. He is one of, if not the top world expert on mood disorders, such as bipolar disorder and major depressive disorder, is an expert on the use of lithium with 30 plus years of clinical experience, and has been a long-standing and vocal critic of the Invalidity and Unscientific Diagnostic Statistical Manual, or DSM, used by mental health providers to diagnose mental illness. He got a BA from George Mason University, then later a medical degree from the Medical College of Virginia, completed his psychiatric residency in 1994 at Harvard Medical School in the McLean Hospital Residency Program, followed by a one-year fellowship in mood disorders at Massachusetts General Hospital. Later went on to get a Master's of Philosophy from Tufts University and a Master's of Public Health, or MPH, from Harvard. He has published more than 300 scientific articles or book chapters with an H-index in the high 70s and 15,000 plus citations. He's served on the editorial boards of numerous journals, has authored several books, including A First-Rate Madness, about how world leaders with mood disorders are actually better at leading their nations during times of crisis and chaos, and is available free on Spotify, I found out, in its entirety, and also other books on the philosophy and history of psychiatry, including The Rise and Fall of the Biopsychosocial Model, Reconciling Art and Science in Psychiatry, my personal favorite, Concepts of Psychiatry, a pluralistic approach to the mind and mental illness, as well as several clinical textbooks, including Mood Disorders, a Practical Guide, and a Clinician's Guide to Statistics and Epidemiology in Mental Health, Measuring Truth and Uncertainty. He currently directs the Mood Disorder Program in the Psychopharmacology Consultation Clinic and serves as a professor of psychiatry, all at Tufts University and Medical Center in Boston, and is a clinical psychiatry lecturer at Harvard Medical School. Dr. Ghaemi has been featured on CNN, MSNBC, Fox, in the New York Times, and other major media outlets. He speaks regularly at conferences, gives lectures, and also has a podcast with an easy-to-remember name, the Ghaemi Psychiatry Podcast, which I highly recommend for providers and curious patients. And as I'm reading this, also realize why you haven't released enough episodes lately. At this point, I feel like the guy announcing Tiger Woods before he tees off on the first hole at a major, as I didn't even touch on so many of your professional accomplishments and accolades. And, Dr. Ghaemi, seriously, on a personal note, you've been incredibly influential on the way that I, as well as several of my residency cohorts, practice psychiatry. helping us to understand the importance of the manic depressive illness concept, as well as appreciating the difference between disease modifying and symptom modifying treatments. This is the first time I've ever spoke with Nassir directly, and if you can't tell, I'm pretty excited to have you on as my guest today. So without further ado, Dr. Ghaemi, how are you doing?
Thanks for having me. I'm doing okay, thank you, and I appreciate the chance to chat with you.
Absolutely, absolutely. I've got to warn you, I've got some lengthy question stems in order to demonstrate things that I already know or things that I already think I know, but I'll keep the first question pretty straightforward. Tell us just a little bit more about your professional journey and what you're most passionate about at this stage of your career.
Well, let's see, the professional journey. To try to be brief about it, I think I went into psychiatry in medical school, keeping an open mind about other specialties, but always feeling in the back of my mind that I probably was going to go into either neurology or psychiatry because I was interested in the brain and behavior. Um, Equally, really, part of the reason that I went to psychiatry rather than neurology was it wasn't just the brain that I was interested in. I was interested in what makes people tick. Um, I was lucky to be able to get into McLean Hospital psychiatry residency program in the Harvard system in the early 90s, which is truly an incredible program, much better than it is now, by the way. And partly because at that era in the 90s, there was this transition happening between the more psychoanalytically run profession of the 60s, 70s into the more biologically, essentially pharmacologically run profession of the, we might say 80s, 90s is when it started, but it really took over in the 90s into the 2000s. There was this transition period between the 80s and 90s where a lot of the psychoanalysts were still around, and biologically oriented people also were reaching their prime. So we got exposed to both groups in a lucky way, I think, because I think since the 2000s, since most of the psychoanalytic community has decreased in size and influence, even though obviously they're around, they're nowhere near as influential and available. Now that, I was among those and still am who criticized that psychoanalytic hegemony of the past. But as a training experience, it was good. It was very useful to interact with people with that level of expertise around the more psychological and specifically Freudian aspects of our profession. Um, so for me, residency training was just a joy, learning from all these different kinds of people and learning about myself. So my journey was partly in the beginning, a lot of it was learning about myself and, and more about who I am as a person and the privilege of being able to translate that into a profession at the same time. And then as I was, in the field and learning about it as a resident and in my early years, of course, I was more interested in research and psychopharmacology because that's where new knowledge was happening, and I thought it was important to have that kind of knowledge, obviously. Bipolar illness became a focus of mine because that's where I felt there was the least knowledge at the time, and it still is, and where the most impact could be had. There were, dozens of antidepressants and dozens of antipsychotics for depression and schizophrenia, but there was only lithium for bipolar, and Depakote was new when I was a resident. And then Tegretol just come out, and Lamictal came out a few years later, and that's still all we have actually for the 4 mood stabilizers. People were using antidepressants wantonly, as they still are, and making these patients much worse. And I was shocked to find out as a senior resident that that was the case, and figured, well, I could probably educate the profession and make things better by getting people to stop using antidepressants. 30 years later, I can say that with statistical data, nothing has changed and people have not learned. But I've spent a career studying that and trying to teach about it. So really the journey then became about these specific clinical topics, especially in the field of bipolar illness, antidepressants, new drugs. I got to know Frederick Goodwin, who was an expert in the field, former director of the NIMH, first author of the main textbook, Manic Depressive Illness. I got to know him in the late 90s, and he had just left NIMH and gone to George Washington University, where was working for a few years. And his mentorship was central to my career and made me, having trained in the Harvard system, I thought I knew a lot, but learning a lot more from the greatest minds in the field like him really continued my education. And he was my closest mentor until he died 2, 3 years ago. Um, and he introduced me to other people like Haga Pakiskel and later Athanasios Koukopoulos in Rome, who I met in the mid 2000s. So by then I was nearing 40 and I had been in the field for about 10, 15 years. But again, I was continuing to learn more from people who knew a lot more than I did. And that changed a lot of my thinking as well. And eventually what happened, right around then, by the time DSM-5 came out in 2011, I realized that clinical topics of debate that had been my focus for the prior 10, 15 years mattered, but there were deeper problems in the profession. It wasn't just that we were misdiagnosing bipolar relative to unipolar depression, which is something I'd focused on, but that actually the whole concept of so-called major depression was false. And in fact, all of DSM, almost all of it, with the exception of schizophrenia maybe, and to some extent bipolar, are false concepts in the sense that they're invalid, that they're not real. And DSM-5 process was what led me to that conclusion, in addition to learning more from people like Koukopoulos in the European system, who had knowledge about what psychiatric diagnosis was outside of the United States post 1980 and DSM-3. And so then the last 10 years or so of my psychiatric journey have been, going into my 50s, a time where I'm realizing that the profession is more radically problematic than I thought it was. Diagnosis is a central issue, but also treatment with the medications, because the other thing I learned after spending 4 years at Novartis in the private pharmaceutical industry, about 7 years ago, I did that. And then I got some very new insights about psychopharmacology that I never had in academia, one of which was this whole distinction between symptomatic versus disease-modifying effects, which I really had not understood and had not heard other people really describe. So for me, that's a radical change in how I think about how we should be using our medications. Um, and so now, those are my points of focus. I think we need to get serious about moving away from DSM for the future. Instead of having a DSM-6, which is already in process, we need to really get away from that. And I think regarding the medications, we need to have total change in our way of thinking about drugs. And instead of just getting a super Tylenol that's better than Tylenol, like ketamine or psilocybin versus SRIs, that's all going faster down the same dead-end alley. We need to really think differently and look for disease-modifying drugs, which we're not doing. And unless we do all that, I don't see how our profession in the next 20 or 30 years is going to be radically better than it has been in the last 30 years as I've observed myself up close. That's my summary of where I've been and how I've gotten to where I am now.
So I can't tell you how lucky I feel for being exposed to your ideas and some of the ideas of the folks that you mentioned, Akiskel, Koukopoulos. You talk about how, for example, anxiety is not a diagnosis, and your criticism on the overdiagnosis of ADHD, ADD, and then to take another look at so many of the diseases that I've been trying to treat throughout training and early in my career, and saying, are these related to a mood illness or even a subsyndromal mood illness that you've talked a lot about? You've taught me to rely on three major aspects of the clinical interview to glean information that helps me distinguish one diagnosis from another. that being course of illness, family history, and response to medications. And coming out of residency, I was a little bit despondent by not seeing patients getting much better. And I think we're in a very tough field for that. It's not as simple as lowering blood pressure or lowering blood sugar. But since I have changed the way that I practice, I have a new vigor for what I do and excitement for the future. But before we get into that, because I want to talk to you a little bit about lithium, especially at low doses. Tell me, why do you think the DSM exists like it does now, and why do we have so many invalid and unscientific classifications? Because I know that not everybody in our field, not all of the scientists are trying to make these invalid, unscientific classifications. So why does that exist?
Well, I mean, at a very basic level, the reason DSM exists the way it is now is because of an inherent conservatism of the human mind. We tend to accept the status quo, and it takes a lot for us in any profession, in any group, on any topic. It takes a lot for people to overturn the status quo and take a risk on something completely different. We're risk averse, and we respect our parents and our grandparents and our forebears and our teachers. And they all taught us all this, so we just continue it. It's very, very rational, very natural, but also very unscientific, because science is all about paradigm shifts and blowing things up and being revolutionary. Um, but that's also why, even, scientific change happens very slowly, and major changes happen very infrequently, because it goes against the grain of human nature and society. We tend to be sociable. Human beings are conformists. Conformism is a good thing for social purposes, but it's a bad thing for intellectual and scientific purposes. Um, so I think what happened with DSM was that in 1980, when DSM-3, the third revision, came out, it was a radical change. The people who made it were not conformists. They were actually changing the way psychiatry was, which at the time was this very psychoanalytic Freudian hegemony, as I mentioned. And in that sense, it was a good thing, and they thought they were doing a good thing. And they were, to some extent. For instance, the schizophrenia concept got established in a much more scientifically reasonable way, requiring chronic psychosis for 6 months or longer, whereas before people used the phrase schizophrenia in the psychoanalytic community, they use it if you had a panic attack. They'd say you have schizophrenia, any kind of abnormal thought. So that was good, but in part, what happened was DSM became a victim of its own success, and also, as with every revolution, after the revolution is over, the revolutionaries become very conservative, and they then become dictators and tyrants. So what happened was the DSM-3 leaders, who were leaders of change in 1980, became, with DSM-4 and afterwards, protectors of the status quo. They didn't want their DSM to change anymore. Whereas they had claimed when they made DSM-3 that, they admitted that they didn't have validity data. They only were establishing reliability, agreement, dictionary. And they said that this dictionary would change over time with research, and then it would become gradually more valid. Well, the problem was, the success was, people liked it so much, nobody wanted to change it. And when DSM-4 came out 14 years later in 1994, the leaders actually sent out a dictum to all the members of the committee that they should not change anything, except for very minor changes if they had a huge amount of evidence for it. So it got set up so that 90 to 95% was the same in fourth edition, and then in fifth edition, similarly, 90 to 95% was the same. So you have this stagnation, conservatism that's built into the system because people like it so much, without realizing that by doing so, they're actually betraying the original intent, which was to change it over time and make it more valid. And then when someone like me comes along and says, hey, it's not valid, they get mad. But they don't have any scientific basis to stand on. All of the DSM field trials are only establishing reliability. Not a single one looked at validity. And that's because validity is a lot harder to show. And if they did, they would find that they're not very valid, and then they'd have a problem. They'd have to try to sell diagnostic criteria with the admission that it wasn't true. Whereas now, they sell it by saying, "Hey, we all agree on it. Let's use it," and they leave the question of its truth or falsehood unstated.
Yeah, I think it's difficult for us humans to deal with uncertainty, and we are in a field that still has a rampant amount of uncertainty. I mean, to go back to Thomas Zah's what is mental illness, that is still a very valid question, and we have some answers, but we have a lot more pseudo answers. Answers that are propped up by experts saying that they're the answer, like you're pointing out, without the actual evidence behind it to prove that validity. Um, and one of the kind of most influential clinical practice changes that I've made since I got out of residency, actually, is conceptualizing mood fluctuations on that manic depressive illness spectrum, loosely correlating to what we call bipolar disorder and major depressive disorder today, not to be confused with minor depressive disorder. And if I understand your reasoning, the most important facet behind this conceptualization is that it allows clinicians to recognize those patients that are most at risk of the worst outcome that we can have in psychiatry, death by suicide. Can you give that statistical breakdown that you've given before on suicide and expound upon why we moved to the less scientific bipolar and major depression classification?
Well, let me take the second part first. In 1980, one of the radical changes that was made with DSM-3 was to create the terms bipolar disorder and major depressive disorder. Those terms were not used before. MDD, at least, major depressive disorder, was not used. The term bipolar was used, but bipolar was seen as a subtype of manic depressive illness. So the phrase that used to be used was manic depressive manic or manic depressive depressed. In other words, you could be manic and be manic depressive, or you could be just depressed and be manic depressive, not manic at all. But the DSM group decided to take that second group that was just depressed and label them differently, major depressive disorder. The other phrase that was used for them was unipolar depression. And bipolar and unipolar were both the same illness. They were not different illnesses. They were parts of the same illness, which was an overarching term, manic depressive illness. So most American psychiatrists knew that before 1980, because DSM-3 had not yet separated it out. But most American psychiatrists either forgot it or never learned it since 1980. And so people think that bipolar and MDD are two legitimate and obviously different concepts, whereas in fact, they were viewed as the same thing for 100 years. And for reasons we can get into scientifically, they aren't different in my view. The validity studies do not really support them being different. Suicide, of course, is something that happens with depression. But you can be unipolar or bipolar depressed. Unfortunately, because of the DSM distinction between bipolar and MDD, the thought is that the one depression needs to be treated differently than the other. So with the so-called MDD patients, you give so-called antidepressants like serotonin reuptake inhibitors, SRI. With the bipolar patients, you give mood stabilizers. You shouldn't give antidepressants, even though people do. But at least people also give mood stabilizers, often like lithium and others. Well, it turns out that lithium is proven to prevent suicide. It's the only drug that's proven to prevent suicide in randomized trials. Clozapine has a prevention study in suicide attempts, but only lithium is proven to prevent suicide, completed suicide in randomized trials. So it is an effective drug. It is a useful drug for suicide prevention. Very, very, very likely. And so when it's given to the bipolar patients, it may help them. But it is withheld from the MDD patients because they're seen as a different kind of depression. And so it's not helping them. We're not giving it to them. Furthermore, the SRIs that we give to them actually can make some of them worse in the sense that because they have, if this manic depressive illness concept is correct, some of these people we're labeling unipolar depression actually have the same illness as the ones that have bipolar illness. And we know that antidepressants can make people manic or make them have mixed states where they have manic and depressive symptoms at the same time. A lot of these unipolar patients actually have mixed symptoms. They have some manic symptoms along with their depression. Not enough to meet the DSM definition of bipolar, which is totally made up anyway, 4-day cutoff that has no scientific evidence for it, but enough that people think it's not bipolar, so it's okay to give them SRIs. They get mixed, and then they get suicidal. And so this debate about whether antidepressants cause suicidality over the years, it's been always a pro and con. We love the drugs, we hate the drugs, as opposed to really a clinical issue, which I think it is, that some people with so-called unipolar depression actually have mixed states. They get worse on SRIs, and they do get more suicidal. And so that's another way we're not helping the suicide problem, because we're not giving the drug that can prevent it, lithium, and in some people we're giving drugs that worsen it, the SRIs. When you add it all up, 95% or more of people with suicidal ideation will not die by suicide.
I probably mention this on every other episode that I do. It never made sense to me, and yet I was the one that was made to feel crazy about the fact that I was supposed to use a drug for a depressed and suicidal patient that has the risk of making them more suicidal or tipping them over the edge to actually attempt suicide, in lieu of a drug that has a 4 to 5 times reduction in the risk of suicide. And that not only bothered me, but then to be told that idea was silly for me to want to use even a low dose of lithium in a depressed patient, which I personally believe should be the first line medication based on the benefit to risk ratio. I may come back to my next question in a minute, but now that we're already on it, I mean, one of my biggest kind of early in my career clinical philosophies is start with a drug that offers the best benefit to risk ratio. And to me, lithium is without question the best drug at preventing severe mood fluctuations in what we now call bipolar disorder, with the largest effect size. It's the most preferred agent by patients with the condition, and it's much safer at high doses than what I was taught in my medical training. However, I'm more interested in your views on the therapeutic potential of low and extremely safe doses of lithium for those patients who would have been considered manic depressive illness spectrum in the past, despite never experiencing those overt manic episodes. Just to give a little bit of context here for listeners, low doses of 150 to 300 milligrams a day compared to bipolar doses of 900 to 1500, or even supplements containing lithium orotate, which is more neuropenetrating, have led to some pretty incredible results in my practice. When I alluded to having a new vigor for what I do, it certainly does not lead to an incredible result in everybody. But for example, in the last year, I've had a woman who suffered from severe PMDD, formerly called PMS, for about 20 years with severe mood swings, emotional turbulence, suicidality in the week leading up to her menstrual cycle. I started her on the lowest dose of prescription lithium, which is 150 milligrams of lithium carbonate. And she's now had 3 different back-to-back menstrual cycles without any sort of emotional turbulence. I've had early potential success in a suspected CTE patient, which I know that you've talked about a lot. And honestly, one of the kind of crazier responses I got was actually in an autism patient, autistic spectrum disorder. I did therapy with this patient for nearly 2 years, and he had a lot of rigidity in his thinking and ended up leaving the therapy or not coming back for about 6 months. And he came back with his parents. And this is somebody who would dress essentially in Gothic clothing at every single appointment, And we started him on that after talking to his parents. I said, I don't know if it'll help, but I think it may have the potential to help. 4 months later, his parents have said that he comes up and asks them how they're doing, how their day went. Very pro-social behavior. He told me at one of our recent appointments that he's thinking about getting a new wardrobe and expanding his. And I never ever had been taught that. I never would have thought that it would have been successful. But after using it in so many patients without any major side effects or any real concerns on a safety profile issue, I've started to use it a lot more. And some people think I'm crazy for using it that much, but they just hear that lithium. They just hear that word lithium, and there's all this other connotation that goes with it. Dementia. What other uses do you think it has the most promise for?
Yeah, so it's an important topic. I would say first it's worth commenting that traditionally lithium has always been used at high doses. Um, John Cade, who discovered its use in psychiatry in Australia in 1949, he gave it to I think about 10 people. Two of them I think died, and he actually got investigated by his hospital for harming patients with a toxic drug, and after that he refused to prescribe it. He never gave it to anybody again, even though he became famous for lithium. It was the work of others, Mogen Skau from Denmark in the 1950s and Sam Gershon in Australia, who figured out that you had to check levels, you couldn't go above a certain level, and so on. It's a toxic drug, but even so, they still were giving it at levels that were very close to toxicity. If you think about it, if we use it at the zero point 0.8 to 1.0 level, which people view as therapeutic, it's clearly toxic at 2.0, which is twice as much as that. And you start getting borderline toxicity at 1.5 and above. Lithium would never come to the U.S. market today with current regulatory guidelines of the FDA. Current FDA guidelines for drugs that are being developed in the pharmaceutical industry are in early phases. If you can show animal toxicity, in human toxicity, usually though animals enough, but if you take it to phase 1 human trials, you have to show that there's no toxicity at 10 times higher than the therapeutic dose. No toxicity at 10 times higher than the therapeutic dose to take it forward. That would mean that lithium would have to be non-toxic at a level of 8, which is fatal. So lithium would actually never pass muster to come to the market based on safety in the U.S. today. The only reason we have it is because it predated the FDA regulations, which started in the 60s, 70s, and lithium came along in the 50s. By the way, same thing with amphetamines, which are clearly neurotoxic and kill brain cells. They would never be approved by the FDA today, even though we widely prescribe them. That's not to say we shouldn't have these drugs that are toxic. There's an old saying from Paracelsus, the great founder of modern pharmacology in the Middle Ages. He said that all drugs are toxic. It's only the dosing and indication that makes them therapeutic. So I do not claim at all that lithium is safe. It's a toxic drug. But if you get the dose right and the indication right, it's very therapeutic. And that holds for actually every drug. It's just that lithium is more toxic than others at the doses that are close to the doses that are commonly used. 0.8 is too close to 2.0 in my field, in my view. And that's another reason I like to use lower doses now. I learned that from Koutopoulos, only 10 or 15 years ago, pretty far along in my career. I had been pretty skeptical about it. I followed all the rules beforehand. I was constantly titrating people up to 900 milligrams and more and getting the levels around 0.8 to 1.0. But in the last decade, as I followed Koutopoulos' advice to try lower doses first, I found that if you went slow enough and low enough, people got better before you needed to go higher. And that confirmed for me that he was right, that we didn't need the higher doses. And I think it's a residue of 40, 50 years from the 1950s to the 1990s, when lithium was the only drug approved for bipolar illness or available. And people just used it at higher doses because that's all they had, or they wanted to maximize its benefits. But the other point that you're making, besides the fact that it works at lower levels for mood illness, bipolar and unipolar depression, is that it may work at these lower levels for lots of other things. Now, I'm not going to sit here and say it's cure-all for everything. We should give it for everything. But I will say that those who are so skeptical about it should know that there's no real disproof. And that at the very least, it ought to be used and studied in autism and other things more carefully. All we ever have is case reports, and those are usually high doses. It would be interesting to see how it does at lower levels for lots of different things. The one place where I think we do need more data, but I think we have, uh, decent. We have the beginnings of decent data, and a lot of my own clinical experience is with the mood temperaments. So dysthymia, hyperthymia, when people are mildly manic all the time, cyclothymia, and this can be measured using the TEMPS scale, EMPS, that Fiscal developed, and that I revised to make it clinically useful by giving cutoffs. Um, I increasingly have been giving this scale to all my patients, and the patients that come to me who score high on hyperthymia and cyclothymia tend to be people not necessarily who were diagnosed with bipolar or even viewed as being in the bipolar spectrum, but usually diagnosed with ADD, generalized anxiety disorder, and sometimes so-called MDD. So my joke equation is that if somebody comes to you with the diagnoses of the comorbidity of GAD, MDD, and ADD, then they have cyclothymia. And that's what I find a lot. And they come in on benzos, SRIs, and amphetamines, and you give them 300 of lithium and take all the other stuff away, and they're much better. Or 500 of Depakote. Low doses of lithium and Depakote seem to help a lot of these people. That's the group that I think there's a rationale that's pretty good diagnostically, but it's interesting to think it's really about understanding temperaments more. You're treating the temperament, but you're not treating the mood symptoms really. You're treating the effects of the mood symptoms. Because they're always up and down in their moods, manic or depressive to a mild degree in cyclothymia and hyperthymia maybe, they have the effects of distractibility, sad mood, down mood, and anxiety. So the effects are being diagnosed by our current diagnostic system, and symptomatic drugs are being given for the effects. It would be like people having fever, chills, and night sweats and getting Tylenol, an anti-chills pill, and an anti-night sweat pill instead of treating the underlying pneumonia. Similarly, for us, we're treating the symptoms of attention, mood, and anxiety, and we're not treating the cause, which is the mood temperament. And that's where the low dose, not just lithium, but low dose Depakote too, probably, is helpful. And that's a lot of people. The people that are being diagnosed with GAD, MDD, ADD, that's a lot of people these days. And in my routine outpatient private practice now, that's at least half the people I see. And 20 years ago, I would not have known to do what I'm doing now with them. So I think it's a pretty big change if one realizes that that's what's going on. It can change really how you see patients and how you treat them for the better. Because if this is all correct, they end up on low doses of one drug instead of high doses of three, and they do a lot better.
And the reduction in polypharmacy, the lack of definitely very many major side effects at these extremely low doses. It really, I can't say enough. It has reinvigorated me for what I do and for the potential in the future. I think that there's a lot of factors that go into this demonization of lithium. I mean, I always thought it was strange that I get all these electronic medical record warnings about lithium with serotonin syndrome, which if you talk to the leading serotonin syndrome or toxicity, better terminology, serotonin toxicity experts, the lithium does not cause any sort of serotonin toxicity. And there's so many different warnings that go into it. I think the lithium chloride catastrophe with cardiologists and heart health in the 1940s, right around the same time as John Cade was making his discoveries, which that's a whole nother incredible story on its own. But I think all of these kind of play into this fear of lithium. I use it, the example I use with patients or even other providers who think that I'm using something dangerous is lithium's in the same column of the periodic table as sodium, which is right below it, as potassium, which is below that. And if you have too much or too little sodium in your bloodstream, you can seize. If you have too much or too little potassium in your bloodstream, your heart can stop. So my philosophy is that absolutely too much lithium and getting anywhere close to too much lithium can be toxic and potentially fatal. But the nuance there is, are some of us in a lithium deficient state? And do we need a little bit more lithium? And if you give it enough time, Rif Al-Malik, hammered into my brain that lithium gets into the neurons and it doesn't have a great transport out of the neurons. So it can accumulate in neurons. And if you give the low doses enough time, and I think that's why we see these other antiviral and anti-inflammation effects that build over time with the drug. If you have the time, you can get incredible results without running that kind of risk of the patient's safety. But can you comment on how safe you feel like that 150 milligram dose is, or even lower than that, the supplemental doses?
Yeah. So if you take the FDA rule, which I think is I think that's a very conservative guideline. Tenfold of the dose should be safe. So 10 times 150 would be 1,150, right? Something like that, or 1,500.
Yeah.
That's the higher end, I would say, of safe dosing. So 150 probably is a safe dose. Certainly less than that is safe. And if you go to lithium orotate over the counter, usually comes in 5 milligram pills. 5 milligrams of lithium orotate is equivalent to about 25 milligrams of lithium carbonate. 10 times that is 250 milligrams, which is a safe dose. So I think the supplemental lithium doses that are available over the counter are definitely safe doses. There's nothing harmful from taking that. There's never been shown any harm in humans. And I've been letting people take it. It's not prescription, but I've had patients who want to take supplements instead of prescribed lithium. And I also follow people whose doctors won't prescribe lithium to them, so they get supplements instead. And we follow their kidney function and thyroid function, and we haven't seen any worsening of kidney or thyroid function in over-the-counter supplement doses of lithium.
I
Worth
haven't
pointing
either.
out that those doses, 5 milligrams of elemental lithium, which is what's in the supplemental lithium orotate, that's equivalent to 25 milligrams of lithium carbonate, is 5 milligrams of elemental lithium. That's a high dose from a dietary perspective. Our diets, we're supposed to get about a milligram of lithium a day. So if you get 5 milligrams, that's 5 times more than the average amount. And that's actually a lot of lithium, but it's very safe. It's not anything that would harm you. Many people do have a deficient diet where they have zero lithium or practically zero lithium. And there are lots of geological studies that I know you're aware of, that good for the audience to hear about, that show that they look at places in the world, all over the world, US, Europe, Asia, Latin America, and you can basically measure lithium in the drinking water. And so people who live in that area have zero lithium in the drinking water. They're compared to people who have more than 1 milligram a day. Usually 2 to 3 milligrams a day is what they look at as high levels, which would be, again, equivalent to taking less than 1 lithium orotate pill a day. And the high lithium levels, the so-called high, which is still extremely low, they have 1/2 the suicide rates where they're lithium deficient. And there's one study out of Scandinavia now that shows they also have 1/2 the dementia rates than the people that are lithium deficient. So there's beginning evidence that very low doses of lithium may help prevent dementia. We already know lithium prevents dementia at standard doses based on mood illness studies. In the studies where people have depression and bipolar illness, if they're on lithium, they don't have increased dementia rates compared to the general population. Whereas if they're not on lithium, they have about a 2 to 4-fold increased rate of dementia. So lithium really prevents dementia in people with mood illness, and I think it should be given practically to all of them, at least at a low dose. But it's also suggestive that at very low doses, meaning the supplement type doses, it may have preventive benefits for dementia. It's very, very likely it has preventive benefits for suicide, based on literally over a dozen replicated findings on geological studies. Now, keep in mind, these are not randomized trials, so you will find a couple studies that don't find a benefit. That's always the case with observational research. But the majority of studies find benefit. And since we do have randomized data that lithium prevents suicide versus placebo, standard doses, as I mentioned earlier, it's logical that this benefit is a real effect. Again, it's not definitive because it's not studied at these extremely low doses in randomized trials, but it's very likely.
And is that a reference to Alec Coppin's work?
Coppin is one of the people who
The
studied this. No, the very low dose lithium, you mean? The
No,
randomized
just
trials?
the comparison with placebo.
Yeah,
Yeah.
there's been a couple meta-analyses of this over the last decade. The most definitive one usually cited was by Cipriani and colleagues from the British Journal of Psychiatry around 2013 or so. And some listeners may know that there was one last year from another British group that claimed to debunk this and said that lithium does not prevent suicide. But in their meta-analysis, they actually have the same benefit seen, which was a odds ratio of about zero point 0.4, so about a 60% decreased odds of suicide with lithium versus placebo. But they had included a bunch of studies with no outcomes so that they increased the denominator to make it statistically non-significant. And by this trick, they claimed that there was no effect. But it's actually a mistake to do that because in meta-analysis, if you include studies, especially huge studies where there are no outcomes at all for your outcome, then you're obviously going to make it impossible to show statistical effects. So I criticized that paper on that issue recently, and I think the meta-analyses are contrary to those who are skeptical about drugs in general. I think the meta-analyses do show pretty consistently that lithium is a preventive effect for prevention of completed suicide versus placebo. And like I said, you cannot say that about any other psychiatric drug.
Well, and I think the other factor here is that if you put your patients on lithium, they're going to come and see you less. They're going to have less reliance on other drugs and hospital systems, and that ends up hitting the bank account of some companies that are in pharmaceutical or hospital industry. I kind of wonder if there's an intentional demonization or a covert efforts to try to demonize lithium, because these things are known at the highest, most intellectual levels. But we could talk about that for
No,
hours and
I
hours.
doubt that, to be honest, even. There's an old saying that you should never attribute to I think it's to malevolence what is better attributed to ignorance. My observation, having worked in the pharmaceutical industry, and I've discussed lithium in detail with a lot of people in our company that I worked in and with others, they just have no awareness of this at all. And to the extent they do have awareness of it, they're not critical of it. People that I observed they actually isn't. There is not this level of knowledge at the highest levels of private industry, whether insurance or anything. They're just businessmen. They don't study the scientific literature like this. Many of them aren't even psychiatrists among physicians. So it's not about that. I think it's more just a lack of knowledge is part of the reason people don't know these things. And there is a subgroup of people within psychiatry, but especially outside of psychiatry, who are just anti-drugs. They're anti-psychiatric drugs. And they usually blame the pharmaceutical industry because they can claim that there's some profit motivation. But they can't do that with lithium because it's never been, it's the only drug that's come to the market without any drug company behind it. So they can't do that with lithium. But the fact that they still criticize lithium shows that their ideology is really not about economics. It's about a hatred of drugs, period. I'm all for criticizing drugs when they shouldn't be given. I criticize plenty of drugs. But I think, it's obviously very harmful to have an ideology that all drugs are harmful in psychiatry.
Yeah, and you just don't know the underlying motivations of people a lot of the time, or of companies. But to me, there seems to make there is a large incentive to, whether it is overt, covert, or ignorant, to not use lithium at the expense of other drugs, because it's so cheap, it's so natural, it can't be patented, and it typically makes your patients better than most other drugs. But yes, I mean, absolutely, that's not something you can prove, and that's good to hear you say.
Well, I think
I'll
at the
have to
company level,
think
it's
on that
not
more.
relevant because they're not using lithium. They're developing other drugs. That's relevant more at the level of clinician, the prescribing clinician. But even then, I don't think it's relevant. I don't think clinicians are really focusing on how much things cost. And by the way, you can patent lithium. You just have to have a version of it that hasn't been patented before. So technically, you could
Right.
patent it. Depends on what your animal is.
Well, switching gears here, like I said, we could talk about lithium for hours, I'm sure. But switching gears here, one of the biggest travesties that I see in American psychiatry today is the rate that we are medicating our children. Ronald Kessler at Harvard back in the late 1980s was quoted as saying something along the lines of, mental illness does not exist in children. And at that time, and that might be a little too extreme, but at that time, 0.2% of Medicaid insured youths were on any psychiatric medication. And now the rate of medicating our kids has skyrocketed close to 20%, or 100 times what it was in the late 1980s. And I fear that we're only masking symptoms and actually making their conditions worse in the long term, or even causing conditions that they never would have experienced by altering that brain chemistry at such an early age. The way that I view most mental health conditions, excluding things like autism or trauma, is that they require a higher level and development of consciousness and self awareness that only comes with age and further brain development. And just briefly, to use schizophrenia as an example, it seems logical to me that with the timing of synaptic pruning, or the trimming of connections in the brain, allowing for more focus and intentional thought and action, of the frontal lobe occurring just prior to and during the emergence of negative and cognitive symptoms of schizophrenia, with a similar pruning and maturation of the auditory cortex 2 to 3 years later, corresponding to the emergence of positive symptoms, which are most typically primarily auditory hallucinations. It seems that the best way to describe those are as neurodevelopmental conditions. Unfortunately, I saw one statistic from a colleague, or somebody who trained me, that 2.5% of Kentucky children under the age of 6 had taken an antipsychotic. And that really infuriated me, especially having young kids of my own. Other conditions like bipolar, major depression, OCD, panic disorder, they also don't seem to me to emerge until after we reach that higher level of consciousness post puberty. I personally believe it's kind of, puberty's a prerequisite for most mental illness. But what do you think? Should we be medicating our kids like we are today?
Well, I mean, I would broaden the critique. I think the general issue is that most of our drugs are symptomatic. They're like aspirin and Tylenol for headache and fever. They're not getting at the underlying cause of things. The exception would be lithium and mood stabilizers. And the way you know that they're getting at the underlying cause is that they improve the long-term course of the illness. And those are the only drugs that have been proven to improve the long-term course of a psychiatric illness. Some people will disagree with me about that, but I can provide the evidence for it, that antipsychotics do not improve the course of schizophrenia, and antidepressants do not improve the course of so-called MDD, and amphetamines do not improve the course of so-called ADD. If you look at the randomized trials of those things, which would be a complicated discussion, I would I would be able to explain why they don't actually improve the long-term course. In the case of bipolar illness and unipolar depression, lithium has been shown to prevent mood episodes and therefore improve the course in a good number of people and more than placebo, so statistically meaningful. Same thing with lamotrigine and to some extent with valproate and carbamazepine. So those are disease-modifying drugs because they improve the course of the illness. It's like taking statins, antihypertensives, to prevent stroke and heart attacks, like taking chemotherapies to get rid of the cancer so it doesn't return. That's different than taking nitroglycerin for your chest pain, Tylenol for your fever, and that's all we have with the rest of our psychotropic drugs, amphetamines, antidepressants, anxiolytics, antipsychotics. That's just reducing your pain and fever. It's not improving the underlying disease. And that's the case whether you're 75 with MDD or 12 with MDD, whether you're 67 with ADD or 7 with ADD. It's the same. In my view, it's the same issue with adults and children. With children, obviously, you do have the added problem that you can't know what the underlying disease is in many cases, as you were describing, until their brain is developed enough to show the clinical symptoms in a way that's more obvious, that can be diagnosed. However, you do have the potential hint of the family genetics in the cases of genetic illnesses like bipolar illness. So let me just make up a case. Suppose the mother, the father, and 27 aunts and uncles all had severe bipolar illness and they all committed suicide, and you have a kid at age 8 who's got mood swings. Now you might say, it's just mood swings in an 8-year-old, but he has 27 relatives with bipolar. I mean, that's an exaggeration, but I think that's where family history comes into account, as you said, in the diagnostic process. But what we don't have in children is the course of illness. They're too young to really know the course of the illness yet, and that's why it's very difficult to know what they have. So one approach would be to really be conservative with them. We don't really know what the underlying disease is. To limit the use of medications since they're purely symptomatic otherwise, to the most severe symptoms for the shortest amount of time if you absolutely have to. I think that's a reasonable approach. Another approach would be also to say if they do have a strong genetic propensity for a genetic disease like bipolar illness or schizophrenia, then you might start treating that earlier than you might otherwise, even though you don't have the full-blown disease process yet. And there's some evidence that that's rational to do, like with studies on prodromal psychosis. Some of those studies show that you could give a tiny dose of risperidone and have a better course than if you waited and didn't give them anything. And again, that's not definitive because those aren't randomized trials, and it's hard to do randomized trials long enough. But that's the kind of research we should be doing, but we aren't. But I agree with you that what we shouldn't be doing is saying, oh, just take all these kids, take all their symptoms, give them all drugs for the symptoms, and don't worry about it, especially if we're giving them amphetamines, which are neurotoxic. I agree with you that we should be much more conservative than we are being in that sense.
Yeah, it became a lot tougher for me when I had my own kids, and it became a lot more real to me at that point as well.
And I had the
I,
same
I don't.
experience. I can say I've had two kids that I've parented now into young adulthood, and it was interesting to watch in a upper class environment in a very educated area in Boston, some of which is in private school experience. And interesting to watch their peers. I would say that my guess is that the majority of them were on amphetamines. And there's no way that they all had so-called MDD biologically. I mean ADD biologically. Actually, I don't even think ADD is a valid concept anyway. But the majority were on amphetamines. And it's pretty clear that they were getting it symptomatically for improving their attention, which was impaired for various reasons. Um, so I observed this myself in my kids. It's very hard in this culture, in many places, to raise children and not have them go on something, an SRI, amphetamine, whatever. And it's not always wrong to do that either. I'm not saying that, I don't. I disagree with people who take this really anti-drug approach in a generic sense, and I'm not scolding anyone. But I do think that we need to think much more conservatively about it. That's all I would say.
And that's a huge theme of why I started doing this podcast is the field has tipped way on the side of over treating and over medicating and modifying symptoms instead of diseases. But just like so many things in life, the alternative, the other extreme, the anti-psychiatry movement often goes too far to take out very useful treatments like benzos for catatonia, ECT for certain conditions. There, we've got to find this middle ground, and I think part of it has to do with how our minds work and how our minds like to order information in this all or nothing, black or white way. And that information gets projected to that seat of consciousness, our frontal lobe last, to decide what to do about it. But I think I see that play out a lot on a societal level, but definitely within psychiatry itself. One of the other, kind of all or nothing newer treatments is this kind of what something you've pointed out, this fad of ketamine. It was so relieving to hear your podcast episode on ketamine and the extended clinical trial data in terms of this difference between suicidality and the actual risk of suicide completed. Can you briefly, I know you don't have a whole lot of time, but can you briefly summarize the problems with the ketamine trials? And then if you have time, I'll challenge you on the psychedelic side of things. I'm terrified to challenge you on it, but I do have some questions about that. But I'm more interested in the ketamine suicide risk.
Maybe we can talk about both as our final kind of issues here, because I think they're relevant. Ketamine's a psychedelic, and so is marijuana. If you think about it, I love this. This situation is that we have a spectrum of psychedelic drugs. By psychedelic, and the phrase that was made up by Aldous Huxley, all it really means is hallucinogenic drugs. These are drugs that make you psychotic, and they make normal people psychotic. The only question is, if you take psychiatrically ill people, can they be safely used at all? And generally, they make psychiatrically ill people even more psychotic. So you would think they shouldn't be used in that population. Claim is that some of them can be used in very low doses and have some benefits without making them psychotic, or at least not too psychotic. By psychotic, we mean hallucinations, delusions. Of course, in the case of marijuana, that was the original claim with medical marijuana. But that was just a Trojan horse among the cultural movement to make these drugs available just as happy experiences, just like alcohol. And the medical marijuana laws were just Trojan horses for recreational marijuana, which we've gotten in Massachusetts and a lot of other places. And we know that marijuana, when given to some patients, makes them more paranoid, causes panic attacks, and some people can make them delusional. So,
especially if it's 98% THC, which is so freaking unnatural.
It's the old statement, all drugs are toxic. It's the dosing indication makes it over. So if the dose is high and it's very potent, even more so. But also it's susceptible people, the people that have the biological susceptibility to paranoia, delusions, depression, anxiety, are the ones who are going to have those side effects. So yeah, it can be given. It's to the whole population and safely used in very low doses for happiness, just like alcohol is given to the whole population and safely used in low doses. But it's harmful at high doses and harmful when people at risk, just like alcohol is. Legality does not mean safety, and that's what the millennial generation hasn't seemed to understand. And Generation X, like me, we know
I'm
that.
a millennial.
I know you are. That's why I'm mentioning it, because I think there is a generational issue. Generation X know better. The baby boomers were all a bunch of hippie pot users in the 70s, so they know better, but they don't like it, so they support marijuana too. Now the next step is ketamine. People haven't tried to legalize ketamine for entertainment purposes, but it is legal for treatment purposes, at least for anesthesia, although it's off-label for depression. But ketamine is now available and legal for depression, indicated for that, at low doses. And again, the FDA rule was that tenfold distinction. Now they knew that at the doses given you get dissociation, but it's just mild enough that it's tolerable. That's what the FDA was thinking. So ketamine, I think, is being overused, and I think I will combine my critique of ketamine with my critique of psilocybin and MDMA and any other psychedelics that people want to use. That basic critique I have is not that they're addictive. My basic critique is not that they're toxic and harmful, although they are all of those things at high enough doses. They may not be at very low doses. And people who say they're not addictive, they say they don't have withdrawal syndrome. Yeah, but they cause psychological addiction, which is still addiction. Just like amphetamines don't have a withdrawal syndrome. Cocaine doesn't have a withdrawal syndrome, but they're still addictive. So that's not a rationale to say they're not addictive. But that's still not my main critique. My main critique is that they don't solve anything. My main critique is that they're just symptomatic, like Tylenol and aspirin and all the other psychotropics. If Prozac is Tylenol, psilocybin is super Tylenol, ketamine is super Tylenol. That's not a solution. It's not transformative. It doesn't take the field anywhere better. You're just getting symptom benefit more quickly. Maybe better symptom benefit, but still it's just symptom benefit. It would be like taking somebody with severe cardiovascular disease and saying, hey, you know what, this drug gets rid of your chest pain 10 times more and 5 times more quickly. The guy still has a heart attack 6 months from now and dies. So you haven't changed that. And that's the way it is with so-called MDD and with depression and so on, with psychedelics and ketamine. It's not a long-term solution. Separate from the harm, which was worth mentioning, I've had my cases of patients who've gotten manic and psychotic on ketamine and have gotten addicted to it, bipolar patients. I've had a case of a young woman with ayahuasca who took ayahuasca, not treated, but took it in a so-called, I don't know what they call it, supervised setting with people who are experts at it. And she developed psychotic depression followed by catatonia for 4 months hospitalized, requiring ECT, and still has not completely recovered. So the claim that these drugs are safe and there's no problem is just patently false. And the question only is how unsafe are they and at what doses compared to how much benefit you get. And since the benefit's only symptomatic and it's super Tylenol, that doesn't outweigh the harms in my view. I will say though that the one scenario where they might be useful, if it's proven, is what people seem to say about PTSD with psilocybin and some of the psychedelics. If you can take a dose or two and then get, it's hard to believe that 3 sessions of psychotherapy is going to cure it, but suppose even a few months would be good of psychotherapy, and then you're markedly better for a year or two, that's worth it. Everyone would agree that that's worth it. But these studies are not randomized for a year or two with placebo and the placebo psychotherapy to prove that. And until they prove it, I don't know why we should have unscientific low levels of thresholds for bringing these things to the market when they are harmful as well. That's my general view of psychedelics.
Well, you defended my follow-up question without me even asking it. That's what I was going to mention is, I do think that there is tremendous potential for more neurotic or anxiety-driven depression as well as PTSD. I'm of the ilk that if I can give a treatment to somebody once or twice that will keep them in remission for multiple years from their symptoms, it may not be disease modifying in the ultra long term, but a couple of years is a pretty long term to not have to rely on other substances or medications.
It might be disease modifying.
If the data bores that out.
Yeah, it might be disease modifying. The PTSD is a chronic long-term condition, so if you get someone notably better for a year or two, that's disease modifying. It's getting at something underlying in biology, and it's showing it in the clinical course. And we don't have anything for PTSD, and PTSD, so drug-wise at least, we don't have anything. EMDR is actually a pretty good treatment for PTSD with just a couple months of treatment. So, if this can be another option to something like EMDR, that's great, and I support it. But I do think that there's a cultural aspect here, which is I think a lot of this medical talk is just subterfuge for those who want recreational psychedelics. That's going to be, I will predict, in Massachusetts, we have a ballot question this year for medical use of psychedelics, of course, given by non-physicians. So we physicians, we oppose it. But I predict if it passes that in 3 or 4 years, the same group that did this, which is the same group that got the marijuana laws passed, will come back with recreational psychedelics. And that might pass too, because there's enough millennials and Generation Z people. Generation Z is going to be the biggest age cohort in the population in a decade. So if they go along with it with the millennials and the leftover baby boomers, that's enough people to pass these ballot questions. And I think that's the ultimate goal. People just want to use um, mushrooms. The claim that they're so medically beautiful is really, in my view, a subterfuge for a larger cultural wish to use it. And as far as I'm concerned, people can do that. Just don't pretend that it's a medical uh, panacea when you really just want to feel good. And if that's what this culture wants to do, they can do that. Although in psychiatry, I think we have an obligation to keep warning people because we're the ones that are going to be cleaning up all the harm that happens in the emergency rooms.
Yeah, I think that's very, very well said. I mean, my philosophy is, growing up in the one essentially the drug addiction capital of the world and not knowing it when I was growing up. My generation has had drugs thrown at them, and so with where we're at in terms of this drug epidemic, which is a huge passion of mine, I really think that, I mean, we have to legalize things, and the most important thing to me is that we regulate them, that we don't have 98% THC, that we don't have all these other drugs, cocaine, methamphetamine, that are cut with all kinds of substances beyond the obvious fentanyl. Um, uh, real, I was hoping you mentioned this on your podcast, and always was a little skeptical and thought it was weird that every time I heard about ketamine's impact, it was that it reduces suicidality. And you illuminated why they used the terminology like that. Can you tell the listeners what I'm alluding to?
Yeah, and if it's okay after that, Ethan, I think we probably should cut it short for today. Maybe.
Absolutely.
Yeah, so suicidality is a general phrase that people use for suicidal ideation, thoughts, suicide attempts, an attempt that is non-fatal, and completed suicide, an attempt that's fatal. Um, about half the patients who have depression, severe depression, will have suicidal ideation, but a half don't. Of the people that have suicidal ideation, 90% never make a suicide attempt. Only 10% do. Of the people who make suicide attempts, 90% never have a fatal attempt. 10% do. Of the people who have completed suicide, 50%, half of them, have never made an attempt before. So you don't have a history of suicide attempts in half the patients. So the first attempt is the only attempt. So if you're saying we're going to prevent actual suicide, suicide attempts is not a good proxy. It's half of them have no prior attempts. Suicidal ideation is not a good proxy because when you add it all up, 95% or more of people with suicidal ideation will not die by suicide. It's a hard thing to study, and usually the numbers are low enough when you start cutting down these numbers that you have to have huge studies for a long amount of time to be able to prove it, which is why lithium is the only one proven because there have been lots and lots of studies. When you add it up in a meta-analysis, you can get large enough numbers. But even there, in the meta-analyses of lithium, there were something like, if I remember it now, 3 suicides on placebo and no, 3 on lithium and 11 on placebo if you add them all up. And this is 50 years of research, thousands of patients. When you look at ketamine, you have basically 2 or 3 studies done by Janssen with S-ketamine. You have a couple hundred patients in each study. It's not enough, not large enough to show differences on completed suicide. So that's why they didn't even bother looking at that. It's not even large enough to show differences on suicide attempts. So they really just looked at decreases in the suicidal ideation scale, where they claim some benefit. But my critique at one level is that that doesn't translate to actual prevention of suicide for the reasons I just gave. And then it's worth looking at suicide attempts and completed suicide, even though the studies don't have the size to prove it. And when you look at completed suicide, for instance, there was more on the ketamine arm than the placebo arm. I think it was like 4 cases of ketamine and 4, maybe 6 versus 1 or 2 with placebo. I don't remember exactly. But they weren't all labeled as suicides. Some of them were suicides, some were deaths, like a motorcycle accident was one case. Well, you might assume that it wasn't a suicide, but maybe it was. You don't know. Opiate overdose is not counted as suicide in these studies, but opiate overdose sometimes is suicide. So, if the ketamine showed 0 suicides and placebo had 6, I'd feel better about it. But the fact that it's really kind of the reverse makes me worry.
Yeah, and again, I can't thank you enough for making me aware of that. It has been absolutely awesome to talk to you and hear some of your ideas on these things. And I think it's so important that voices like yours are raised up in the current state of psychiatry, because hopefully things like this that are trying to reach directly to potential providers and patients to educate them on these topics that are not necessarily or really not in the textbook all of the time. So I would love to have you on again. I'd love to talk about consciousness and how we have all this all or nothing thinking and need to appreciate that gray area and a host of other issues. But I really do appreciate your time and your you taking that time to speak with me and my listeners today. So thank you so much. It's been an absolute pleasure.
Thank you, Ethan. It was nice to be with you.
All right. Have a good one.
Somebody get this guy some help.
Thanks for listening. For more social media content, check us out on all social media platforms at Renegade Psych. If you have any comments, questions, or challenges to the information we've presented here, or if you'd like to be a guest of the show, feel free to email us, renegadepsych@gmail.com. Follow the link in the show notes to our website for source material, transcripts, and additional links for my guests. And if you feel passionate about our message and what we're trying to do, and you'd like to donate, you can also follow the link in the show notes to our website. Thank you.